Good afternoon. It is my privilege and honor to be part of this conference. And this afternoon, I'm going to present the perioperative management pearls on congenital heart disease. As we know, this can be from the neonates up to the grown-up congenital heart diseases. But for this talk, I'm not going to give information on the grown-up congenital heart disease. And this lecture is intended for trainees and other physicians who do not regularly handle congenital heart disease. And these are the talking points. So let's go ahead. There are three basic questions to ask when confronted with congenital heart disease. First is there an anatomic shunt defect? Second, is there an obstruction? And third, is there blood flow to the lungs? And if there is an anatomic shunt, where is the site? How big is the shunt? And where is the direction of flow? Likewise, if there is an obstruction, where is the obstruction? And is the obstruction fixed or functional? And what is the degree of obstruction? Is it partial or is it complete? And if there's blood flow to the lungs, is it increased or decreased? How severe is it? And what is the impact on oxygenation and on ventilation? So this slide shows you three levels of shunt. One is outside of the chambers, which is PDA. The other is across the atrium, ASD, and VSD is a shunt across the ventricles. All has increased pulmonary blood flow with a left to right type of shunt. A commonly known cyanotic heart disease is the trilogy of Fallot, and this pathology has a shunt, which is the VSD, and at the same time has an obstruction to blood flow, which is the atretic or stenotic pulmonary valve. So in this pathology, we deal with a shunt, VSD, an obstruction at the pulmonary or brought about by the right ventricular outflow tract obstruction. And the flow to the lungs because of this obstruction is diminished. So all three are involved. The other types of obstruction may be extracardiac, just like in coarctation of the aorta, or it can be at the valvular level. So patients or children born with bicuspid aortic valve has a smaller aortic valve orifice compared to the tri-leaflet aortic valve. And in tricuspid atresia, as the word says, there is no tricuspid valve. So blood flows from the right atrium to the left atrium to the left ventricle, and there is a hypoplastic right ventricle. So blood from here goes through the VSD, and from the hypoplastic right ventricle, it goes to the lungs. Because of the absence of the tricuspid valve, the right ventricle failed to develop. And the other complex congenital heart disease that's common is the transposition of the great arteries. The right ventricle is related to the aorta, and the left ventricle is related to the pulmonary artery. Totally separate parallel circulations. And for the baby to survive, there must be a connection, as in PDA, or the persistence of the patent foramen ovale, or we enlarge this through balloon septostomy. So those are procedures that will allow mixing of blood to happen in these two parallel circulations. So what are the common problems encountered in congenital heart disease? So as enumerated here, duct dependency lesions, balancing of the systemic and pulmonary circulation, pulmonary vascular pathophysiology, there are cyanosis-related hematologic changes, and the myocardial function of the neonate is quite different from that of the adult. So in the transitional circulation in utero, we both have our foramen ovale and ductus arteriosus, and both exist until 3 weeks of life. But for some, it fails depending on how the lesions are related with the normal or abnormal heart structure. But functional closure can happen for PDA in 2 to 4 days, and in 3 weeks, we expect an anatomic closure. And there are several congenital heart defects that depend on the patency of the ductus arteriosus. And that's why ductus-dependent defects are life-threatening congenital heart lesions. So these slides give us two groups: ductus-dependent pulmonary circulation patients and ductus-dependent systemic circulation congenital heart defects. And what is important to bear in mind is that when we are managing duct-dependent lesions, we need to avoid 100% FiO2 because it will close the ductus arteriosus. We can keep the ductus arteriosus patent by giving prostaglandin infusion. We also need to support the heart, ensuring that we do not depress the heart, that we have good ionized calcium levels. We must be cautious with fluid management and also with our ventilatory management. So the shunts may either be small or large, and depending on the size, there will be differences on the pressure gradient across the shunt, on the direction and quantity of the shunt, and on the influence of our drugs and ventilation. So large shunts, it is important that we understand the relationship of PVR and SVR because the flow is dependent on this relation. And also for large shunts, they are largely affected by the drugs and ventilatory maneuvers that we do perioperatively. Now, complex shunts are those simple shunts that are associated with additional outflow obstruction. Just like in the trilogy of Fallot, there's a VSD, yet there's an obstruction either at the level of the valve and also at the level of the right ventricular outflow tract. And the obstruction can either be partial or complete. And depending on this pathology, again, the shunt magnitude, the dependence on PVR-SVR relationship, and the pressure gradient will vary. So the complete obstruction is not affected by the PVR-SVR, but completely obstructed lesions, the pressure gradient across the shunt will depend only on the size of the shunt orifice. And the reverse is true with partially obstructed lesions. Obstruction may happen at the level of the ventricle, the valves, and of the great vessels. And at the level of the valves, it can be above or below, so that it can be fixed or it can be variable, especially in subvalvar. And again, the direction and shunt flow will depend on the amount of obstruction, depending on the resistance that is occurring in the systemic or pulmonary beds. Moving on, let's try to understand the relationship of SVR and PVR, and simply put it, we want a balanced shunt. So across a shunt, so the orifice may be small or large, but there can be a balancing of this outflow resistance to the systemic or the pulmonary side. Should there be a systemic obstruction, then the direction of flow is going to the pulmonary side. Should there be a pulmonary obstruction, then the direction of flow should be to the systemic side. Having said this, the interaction is further affected by the resistance, not only by the obstruction. So meaning to say, if there is increased systemic vascular resistance, the flow will not be adequate. There will be decreased flow, and the tendency now is for the direction of the shunt to move towards the pulmonary. And in like manner, high pulmonary vascular resistance will lead to decreased pulmonary blood flow and a tendency to shunt flow towards the systemic. So the second table here shows us very interestingly, and I want us to focus on this more closely. It tells us about interpreting the arterial oxygen tension in the presence of physiological states of patients who are with shunts. So our patient can either have a 75% O2 sats, more than 85, or less than 65. So let us look at this more closely. At 75% oxygen saturation in a patient with a shunt uncorrected at that, that's already acceptable. That means there's a balanced flow to the lungs and systemic, so there are no consequences. So this is the symbolism for a balanced shunt, and we don't need to treat it, just let it be. But should there be a decreased cardiac output, a hypotension, then there's need for more oxygen extraction by the tissues. And this is reflected if we do venous oximetry, the mixed venous oxygen tension will be low. And at 75% with this physiological status, that only means that we have greater QPQS. And so the treatment to be done is improve on the cardiac output with an inotropic agent and improve on the relationship of the PVR and SVR as shown here. Because it is increased above 1:1, then we have to increase the resistance to diminish the flow to the lungs and improve on the SVR to encourage more cardiac output. Now, the next situation is at 85%. So we seem to be happy at 85% because it's closer to 100. But this only tells us that there is increased pulmonary blood flow. And maybe because the shunt is quite big, or if this is a patient post-Blalock Taussig shunt or BTS, then there is more of QPQS, it is above 1. So to improve the flow to the lungs, to diminish it, increase the resistance in the pulmonary bed, or better yet, change the shunt, put in a smaller shunt. And in the next situation, if the saturation is less than 65, then this is worrisome. So why is it? Is it because we have no flow to the lungs? We have no flow to the lungs because the shunt is blocked, or the shunt is very small. Hence, the QPQS at this situation, saturations are very low, low blood flow. Then we have to revise the shunt. Or is it because there is so much pulmonary vascular resistance, we're having pulmonary hypertension. Hence, we have to decrease that flow. We have to increase the flow. The consequence of a very high resistance is a poor pulmonary blood flow. And at less than 65, it means the QPQS is less than 1. So diminish the resistance in the pulmonary bed and increase the mean arterial pressure to push more flow that will go to the lungs across that shunt. Now, at less than 65 with a low cardiac output, definitely there is increased oxygen extraction as shown in a very low mixed venous, but the QPQS could be balanced. So the only thing that we need to do is increase cardiac output with inotropic agents. And for either case, when there is lung disease, either at less than 65 or at 75, we will always have low pulmonary venous oxygen tension. And in here, the difference is if it is less than 65, QPQS may be balanced, but if it is at 75, QPQS may be greater. So the difference in management now is if it is cyanotic, less than 65, we optimize ventilation. But if it is 75%, yet our pulmonary venous oxygen saturation is low, then we have to improve on pulmonary blood flow. So this graph depicts it more clearly. You can see here, this is the balanced QPQS. From this side to 10 is greater than 1:1. From here to down the line is less than 1:1. And this is oxygen saturation. So this is at 75% SaO2. If we have low venous oxygen saturation at QPQS less than 1, and our oxygen saturation is also diminished, we don't want to be in this situation, okay? So we want to be closer to 1:1 or a little greater than 1:1, but not too much, because moving on greater than 1:1, while we do not have changes in the arterial oxygen tension, the only way to diagnose this is to get a sampling of our venous blood, either from the pulmonary artery or from the right atrium. So when we are managing uncorrected congenital heart disease, the CVP support to sample the right atrial blood. If it is, the trend is going down, but our saturation remains the same, then we have to do something, support the cardiac output, diminish the flow to the lungs by increasing pulmonary vascular resistance, as shown in the table earlier. Moving forward, the flow to the lungs can affect the lungs and lead to pulmonary arterial hypertension. And such can either be pre-capillary type or post-capillary type. And here are the examples. VSDs and ASDs are pre-capillary types. And any lesion beyond the left atrium or after the left atrium that leads to pulmonary hypertension are classified as post-capillary pulmonary hypertension. And to be nitty-gritty about it, it can be surmised that both will have higher mean pulmonary artery pressures, and to differentiate, it will be in the wedge pressure measurements or LA pressure measurements. Greater numbers are expected in post-capillary pulmonary hypertension. As anesthesiologists, our handle to control pulmonary vascular resistance relies on the arterial oxygen tension, carbon dioxide tension, and pH. And to ensure that we do not lose the patient because of very high pulmonary arterial pressure, so we are having hypertensive crisis, the only way to bring it down is give high FiO2s, promote alkalosis, pH of 7.5 to 7.6, and combine this with low CO2, PCO2, hypocarbia. So promote respiratory and metabolic alkalosis. But on the other hand, whenever we are not properly ventilating a patient, regardless of the pH, whether our pH is 7.35 to 45, but we are hypercarbic at 60, 65, then there will be increases in pulmonary vascular resistance. So acidosis, whether respiratory or metabolic, can lead to further increases in pulmonary resistance. And drugs are administered, available to decrease pulmonary vascular resistance. We have vasodilators, inodilators like milrinone, and we also have nitric oxide. Now, sympathomimetics will increase pulmonary arterial pressures. And the way we manage our ventilation, we have to keep it at or near FRC to decrease the pulmonary vascular resistance. So atelectasis or any compressions or hyperinflation, high PIPs will also aggravate any pulmonary hypertension. So here is a slide you can screenshot that gives how to control PVR by manipulating our FiO2s, arterial oxygen tension, CO2, pH, and ventilatory maneuvers. Moving forward, there are hematologic changes associated with chronic cyanotic congenital heart disease. And secondary erythrocytosis is very popular. They become very polycythemic, but we are also aware that there can be thrombocytopenia and anemia at the same time. The secondary erythrocytosis is an adaptive physiologic mechanism brought about by the stimulation of EPO due to very low tissue oxygenation levels. So there is increase in RBC mass. But we have to be aware that erythrocytosis can either be in a compensated state and decompensated state. And if we get patients who are in the decompensated states, they are those patients who manifest moderate to severe hyperviscosity symptoms like headaches, body malaise, death spells. And at the same time, they also develop iron deficiency problems. And so there is anemia. And microcytic anemia, for that matter, the RBC cells are very stiff, and this now contributes to the hyperviscosity because they cannot be adaptive to the size of the blood vessel. So from hyperviscosity, there can be more thrombosis, and it can even lead to infarction. So cerebrovascular events can happen in congenital heart disease, particularly the cyanotic type of patients. So what are the possible mechanisms of causes of thrombocytopenia? And there are 4 that are given in this slide, but recently they are more conclusive that the causes for thrombocytopenia in cyanotic congenital heart disease is because of decreased platelet production and an increase in platelet activation. And the evidence for the increased platelet activation is the presence of higher levels of platelet microparticles, comparing between acyanotic and cyanotic patients. Thus, congenital heart defects, especially the cyanotic patients, the chronic hypoxemia, can have additional problems of bleeding and thrombosis. And shown here are the various reasons for the bleeding: thrombocytopenia, fibrinogen dysfunction, and deficiency of the coagulation factors that affect the liver function. And thrombosis is because of the hyperviscosity, and also the platelet activation that happens. Furthermore, chronic cyanosis can affect the vascular function. The vessels become dysfunctional in their endothelium. There can be vascular or vessel remodeling, and the patients are prone to vessel rupture. Moving on. Now, how does the heart of the neonates and infants compared to the adults? We just have to remember that whether with or without congenital heart disease, neonates have limited capacity to increase stroke volume in response to increased feeling. The increased stroke volume will be on heart rate, and their heart rates are almost always near maximal. And their heart or myocardial functions are very sensitive to negative inotropism and chronotropic agents. So we have to choose our anesthetic drugs and techniques carefully. Furthermore, the sarcoplasmic reticulum, which is the source for calcium, is poorly developed. So we need to find out the levels of ionized calcium because they cannot tolerate hypocalcemia. And there is definitely a predominance of the parasympathetic system because of the immature myocardial metabolism, immature autonomic nervous system innervation. We also need to remember that neonatal hearts have an increased interventricular dependence. So what happens on the left affects the right ventricle and vice versa. So there's reduced ventricular compliance, there's reduced contractile capacity, there's limited preload reserve, and there can be an afterload mismatch. So the heart depends on coronary perfusion, and this is the equation that determines coronary perfusion pressure, the aortic diastole minus the ventricular and diastolic pressure. And the greater the heart rate, the more that there is lesser time for cardiac filling. And then it's only on diastole that the heart becomes perfused. So the standing principle is that if we have high heart rates, the diastolic pressure must be increased to maintain subendocardial perfusion. But if the diastolic pressure is very low, then it is best to have slower heart rates. And these are the factors that can lead to high left ventricular and diastolic pressure that can affect diminishing coronary perfusion, because that will lead to subendocardial ischemia. So diastolic, systolic, and functions and the volume, and even the thickness of the myocardium. So friends, I hope in the last few minutes I was able to share with you how we can take care of congenital heart disease patients. The goal is always to bridge life and, of course, to improve the quality of life as they grow. The first principle is to understand the main problem. Is the complaint heart failure, or is it cyanosis, or both? And why is it so? Is it a repaired defect or an unrepaired congenital heart lesion? So we need all sources of vital information. For me, interval history is very important. How often is the patient in and out of the hospital? And I would like always to see the chest x-ray and the echo, and also see how the patient is breathing. So face-to-face assessment is very important. Second principle is always apply the basic principles of pediatric anesthesia, our applied physiology, and our knowledge in pharmacology. Always maintaining good cardiac contractility and reminding ourselves about PVR-SVR relationship across the shunt, and do the appropriate management depending on the state of affairs of that congenital heart lesion. However, to know what to do, we have to have good monitoring. So we have to optimize our monitoring. Yes, we need a stethoscope, precordial or esophageal stethoscope because those are breath sounds, heart sounds can never be given by our monitors. But on top of that, I would suggest that we make use of arterial oximetry and venous oximetry for reasons I have explained earlier. And we have to take a close look on the size of our patient so we can choose the right tools and also apply the right computations in terms of blood management, fluid management. And these are the basic things we need to remind ourselves. So if there's anything that we can really control with our drugs is rhythm. And the rhythm is very important because it affects the blood pressure and even the coronary perfusion. And ventilation is another important thing that we have to learn. So the proper circuits to use, the proper way of ventilating this patient will all depend on what is the cardiac pathology at hand. So these are the challenges. Just to summarize, the QPQS, it must always be balanced as much as possible. Remind ourselves what affects vascular resistance in the lungs and in the systemic. How can we sustain good cardiac output, and how can we have adequacy of oxygenation? The challenges are not only on the clinical skills. Yes, we need a confirmation of the preoperative diagnosis to optimally prepare the patient. We need to discuss the technical aspects of the surgeons as well as for us, anesthesiologists, what we need to do, and then ensure good post-operative or post-procedural care. And last but not the least, I think non-technical skills are more important. I'd like to emphasize here, disclosure starts with the informed consent. Inform the parents. Neonatal cardiac procedures, oftentimes we don't have the mother with us. Make use of virtual platforms. Talk to the grandparents, speak to the father, explain the realistic expectations and the limitations that we have at hand. So there should be situational awareness at all times, pre-op, intra-op, and post-operatively. And that can only be possible if we are able to communicate, work as a team, and have the leadership and task management delegated either to the surgeon or to us as anesthesiologists. And last but not the least, please involve this time around in severely cyanotic patients, call a hematologist. They will be of great help for us in making sure that our patients will have a good quality of life. Thank you very much, and let me greet you an advance Merry Christmas. Stay safe, friends. Bye-bye.